All right, so today we're going to be learning about a couple of different hot topics in emergency medicine. We have a series of speakers who are going to be joining us to teach us about some of the critical decisions that we have to make every day in the emergency department. Just a reminder before we get started that no questions will be answered following each of the individual discussions, but please stay around for some of your questions to be answered in the discussion zone. That will be our last session at the end of the talk today. Without further ado, I'd like to welcome our first speaker. We have Dr. Adina Maria Marza. She's an emergency medicine doctor who's going to be joining us from Romania today to talk about post-cardioversion complications. Thank you so much for joining us.
Hello, Halley, and hello, everyone. My name is Adina Marza. I'm an emergency medicine physician from Timișoara, Romania. And I would like to talk about post-cardioversion complications. I don't think my slides are here. Okay. So most of the presentations about cardioversion focus on indication, energy settings, or success rate. But today I would like to focus on what happens after the shock. Specifically, what happens when cardioversion goes wrong. I have no conflicts of interest to declare. So in emergency department, cardioversion feels like routine. Mostly of us perform this procedure many times on a month, and most of the times it works great. The monitor changes, the rhythm converts, and the blood pressure improves. But today is about what happens when the cardioversion works and the patient still crashes. So let me begin with the patient. A 52-year-old patient presented in our emergency department. He was brought by the ambulance. He was complaining of dyspnea and he was diaphoretic. He had supraventricular tachycardia with high ventricular rate and his blood pressure falling. Vagal maneuvers, adenosine, and rate control with metoprolol. They were already tried in pre-hospital settings and nothing worked. This was his first AKG in emergency department. He had regular wide complex tachycardia at 174 beats per minute. And it was suggestive for supraventricular tachycardia with aberrancy. He was already known with the right bundle branch block. Given his clinical signs of shock and aggravated heart failure, we decided that he's with unstable supraventricular tachycardia and decided that the safest treatment was electrical cardioversion. So we prepared the patient, we obtained consent, we explained the procedure, and then we continued with cardioversion. Just that instead of having that life-saving joy, things got complicated because after the synchronized shock for supraventricular tachycardia, the patient developed profound bradycardia, and within seconds he became pulseless. That shouldn't have happened, but it's okay. We started chest compressions. We prepared 1 milligram of adrenaline and said, stay calm, guys, it will pass. It's just like giving adenosine, but a little worse, I think. Fortunately, after the ROSC that occurred in less than a minute, the AKG showed a third-degree AV block with a ventricular escape rhythm of 27. And he had ischemic changes in inferolateral leads. Think about complications by timing. That can be immediate complications that occur seconds or minutes after the shock, like post-shock arrhythmias or asystole or maybe sedation-related problems. That there can be complications that appear in several hours or maybe after several days, like thromboembolic complications or recurrent arrhythmias. In emergency department, we mostly fear the immediate ones because those are the ones we struggle with. So there are few mechanisms for bradyarrhythmia's appearance. Cardioversion may unmask pre-existing conduction system disease or may produce transient suppression of sinus node. medication effect can contribute, especially beta blockers or calcium channel blockers, amiodarone, or even sedation medication. And sometimes myocardial ischemia can further impair conduction. So the point is, the shock itself is not necessarily the cause, but it can expose pre-existing abnormalities that were previously hidden by the heart rate. Finnish cardioversion study provided additional insights. In almost 7,000 electrical cardioversion, approximately 1% of the patient developed bradyarrhythmic complications. More than 50 patients experienced a systole lasting longer than 5 seconds, and 7 of them required brief resuscitation and 2 required external pacing. No ventricular arrhythmias requiring treatment were reported in this study. We have another 2 studies. The first one evaluated arrhythmic complications related to the level of shock energy in electrical cardioversion. And the authors concluded that starting with higher energy level was associated with fewer arrhythmic complications. The other one is a big cohort study that involved almost 12,000 electrical cardioversion. And they said that ventricular arrhythmias related to electrical cardioversion for atrial fibrillation was rare but potentially fatal. And most of ventricular arrhythmias occurred between 3 to 72 hours after cardioversion, and many of the patients had congestive heart failure symptoms. They were treated with QT prolonging medication, and they developed afterwards bradycardia with QT prolongation after the shock. However, in larger data sets, more adverse events become visible. In this study, almost 14% of the patients had important adverse events that required treatment. And sedation-related problems and hypotension were the most common. Higher risk was associated with age more than 85, with coronary artery disease, and sedation with fentanyl and midazolam. So what happened with our case in emergency department? If you remember, after the ROSC, he had 3rd-degree AV block, so we started with atropine, but it didn't work. We initiated transcutaneous pacing immediately, and then he had multiple arrests. On the monitor, first it looked like capture initially, but afterwards it was ineffective capture, inconsistent femoral pulse, and hemodynamic instability. At the same time, we started with adrenaline and dopamine and aminophylline infusion, and we had no isoprenaline in the hospital, and nothing worked. So we didn't know what to do next. We increased milliamperes up to 200 milliamperes. It was the first time that we used so high level. And we optimized contact, we shaved the patient, then we changed the electrode position. It was first anterolateral, then we put it anteroposterior and biaxillary, anterolateral again, and it still didn't work. So in the next hour, the patient had multiple arrests, more than 10, and between arrests, he was with persistent hypotension. His systolic blood pressure was never more than 60, and he was with hypoxemia and severe metabolic acidosis, and he still didn't respond to transcutaneous pacing. So the plan was to send him to transvenous pacing, but in our hospital wasn't available, just 10 minutes away to the Heart Institute, and they said they will receive the patient, but we have to stabilize him for the transport. So we had no other option. We improvised something. We put the pads closer together, like in the picture, one subclavicular left and cardiac apex. And after repositioning, things got better. We immediately achieved mechanical capture, the blood pressure returned, and the patient was stabilized. So we sent him to the Heart Institute for transvenous pacer, and the next day he was extubated and he was with complete neurological recovery. And after a week he was discharged from the hospital with a permanent pacemaker. So the key message is that the life-saving step was not a rare drug or a fancy device. It was just recognizing pseudo-capture and move the pads. Here's a practical ED checklist before you shock. Confirm arrhythmia type and onset, and keep a 24-hour threshold for atrial fibrillation, because this drives to anticoagulation and imaging pathway. Identify structural heart disease, because they are primary risk factors for pulmonary edema and post-cardioversion arrhythmias. Identify sedation risk factors. Choose your sedation agent with complication profile in mind. The literature is far deeper on what not to do than on what to do when you have an unstable patient. So when you it's more important the amount of agent, smallest effective dose of anything, than agent selection. Review current medications, especially antiarrhythmics. Check electrolytes, and better do this procedure in a resuscitation room where you have all the available equipment. Be aware of high-risk flags like structural heart disease, because if you have a patient with heart failure or cardiomyopathy, valvular disease, or coronary artery disease, they are the primary risk factor for flash pulmonary edema. Age more than 85 more than doubles the rate for important adverse events. Pre-procedure bradycardia and concurrent negative inotropic antiarrhythmic, especially class 1 agents. After the shock, continue with cardiac monitoring. Watch for bradyarrhythmias, ventricular arrhythmias, and QT changes. Monitor SpO2, respiratory rate, blood pressure. Do a neurological check 30 minutes after the shock and before discharge, because we have a peak for thromboembolic complications between 24 and 72 hours after cardioversion. Make a 12-lead EKG post-cardioversion and afterwards in dynamics to confirm rhythm and to check for ST elevation or ST depression or QT prolongation. This is most important. And don't forget about discharge counseling. Instruct patients to return if they experience dyspnea or palpitations or neurological symptoms, because 10% of ED cardioverted patients return within 7 days. So as take-home messages, treat the patient, not the monitor. If you don't have a pulse that matches your pace rate, you don't have a capture. So increase milliamperes, increase output, optimize contact, and change the pad's position. Think about worst credible complications, because rare doesn't mean never, and always be prepared with your mental checklist, because cardioverted doesn't mean stabilized. Thank you very much.
Thank you so much. That was wonderful. I think it's so funny that you mentioned that the key point to taking care of this patient was not medications, not anything super fancy, but just changing the pad position. And that really, I think, is relevant to emergency medicine with how much improvisation that we have to do every day.
Yes, it was for us as well.
That's awesome. Thank you so much. Up next, we're going to have a speaker teach us about the expert management of headaches. I just want to give him a few moments to join us from Zoom.
Okay. Can you guys hear me? Can I get a thumbs up?
Yes, perfect. Thank you for joining us.
Yes, okay, great. So I'm very excited to be speaking today, and I'm sorry that I can't be there in person. My name is Miguel Cortel-LeBlanc, and I'm an emergency physician in Ottawa, Canada. I also practice headache medicine, both in the hospital as well as the outpatient setting. I do have a few disclosures. I have received honoraria for advisory boards and speakers bureaus and preparing educational material in the space of headache medicine. And right now, I hold a couple of unrestricted research grants in headache medicine. One of the things that I find most surprising about migraine is that it's one of the most common, one of the most important drivers of disability in the world. So migraine itself is the second leading cause of disability out of all conditions. So think about cancer, stroke, multiple sclerosis, heart attack, migraine's up there. And in young adults, in those under 50 years of age, it is the most important driver of disability and absenteeism from work. And it's not just highly disabling. As we all know, it's very common in the emergency department. It's rare for me to work a shift in the emergency department without having to manage someone with a headache-related complaint. Anywhere between 2 and 8% of emergency department visits can be for a headache presentation, for which the majority of it is migraine-related. And in spite of being so common in the emergency department, there's still little adherence to guideline-based care. So I think that there's no better example about this than how often in many emergency departments we use narcotics like morphine in the management of headache-related disorders, when these medications are associated with medication overuse headache, chronification of migraine, poor quality of life, and actually an increasing likelihood of the person coming back to the emergency department with uncontrolled headache. So gaps exist in the emergency department in how we manage headache-related complaints. For migraine specifically, I think that 3 of the most important ones are that we often undertreat migraine attacks. We may use the wrong medications. And in many emergency departments, we haven't coupled the idea of preventive treatment along with the treatment of an acute migraine attack. So today you'll be left with 3 things. The first is an approach for how to diagnose migraine and distinguish it from secondary causes of headache. The second is we'll review the latest evidence in managing acute migraine attacks in the ED and how these have changed over the last 6 months or so. And lastly, I'll plant the seed about how to incorporate elements of preventive treatments to reduce the likelihood of headache recurring at home. So what does migraine look like? This is a drawing from my, oh, there's just someone on mute, sorry. There we go. This is a drawing that my daughter made at the time she was 6 years of age of what she imagined a migraine monster was like. And as you can see, it's a very aggressive creature. I rendered it on AI, and this is what it put out. You can see that there's lipo for photophobia. There's a person in bed showing that they're bedbound, a sound wave for phonophobia, and a flower for osmophobia. So a lot of sensitivities to simulation. But patients usually don't come with a monster like this to help us recognize migraine from secondary causes of headache. So in the emergency department, what are our goals in diagnosing migraine or other causes? The obligatory first goal is to exclude secondary causes of headache or dangerous causes of headache. And then only afterwards, we focus on determining the phenotype. And the phenotype of what the headache is what actually dictates what kind of treatments we're gonna be given. An acronym that can help can help us remember which are the red flags for secondary causes of headache is SNOOP 10. This used to be SNOOP 4 a long time ago, and now it's SNOOP 10. The next time I give this talk, it might be SNOOP 20 or SNOOP 30. They keep adding Ps. And not to go through all of it, you can screenshot this or have it for your reference, but I'll just point out a few of them. The onset after 50 years of age, this relates to the headache onset, not to when headache is present. So if someone has had headache their whole life and they're 60, that's not necessarily a red flag. But if they've never had headache before and they're having a new headache at 60, 65, then it's a little bit of a red flag. Positional headache is a really important one. It can be a clue of a CSF dynamic disorder. So for example, high pressure headaches like IIH, or low pressure headaches like spontaneous intracranial hypotension or CSF leaks, which actually Germany is one of the leading countries in the world in the managing of low pressure headaches. And papilledema, I want to highlight too. This is the clinical exam finding that I put the most importance on because it's often missed. Patient might have a subtle visual disturbance, but fundoscopy can provide us the only clue that there's a secondary cause of headache. All right, so after we've excluded secondary causes of headache, how do we diagnose migraine? So it's all about the phenotype. Here are two patients that are presenting to the emergency department with headache. The man on the left has a side-locked headache, so a headache that is only in one side of their head. They have a red eye, they're teary, they're agitated, they're restless, they're experiencing a cluster headache. They would get cluster headache type of treatment. The woman on the right, you can see the behavior is very different. So this person wants the world to just disappear. They don't want to move, they want to stay still, they want the lights off. They're more in keeping with migraine. The diagnostic criteria for migraine includes 5 attacks that last at least 4 hours in duration if untreated. And it must have 2 of the typical migraine-related features of the headache. So the headache can be unilateral, pulsing or throbbing, at least moderate in severity, or worse with activity. And you just need 2 of these 4 characteristics. And then it has to have 1 of either nausea or photophobia and phonophobia. And as a clinical pearl, I find that often we may ask patients whether they're sensitive to light and sound, and they might answer no. But then when we ask them what they do during a typical attack, they may actually reply that during an attack, they just want to lay down and turn the lights off, showcasing that their actual manifest behavior is one of photophobia and phonophobia. Sometimes patients present to the emergency department with with migraine, but they're not worried about the headache itself. It's rather a transient neurological symptom that they're wondering whether it could be stroke. And this is a common, very important question for us managing these patients in the emergency department is how do we actually distinguish whether someone's experiencing a migraine aura or a stroke or TIA. So the diagnostic criteria for migraine aura includes at least 2 episodes of a typical aura. So a typical aura can be visual or sensory, speech and language or motor. And it has to have at least 3 of the 6 features. And these are really important because basically stroke and TA for most of this is they're almost the opposite features. So in migraine aura, each aura spreads over the course of at least 5 minutes. What does this mean? So for example, a visual scotoma where visual disturbance might start in one corner and, oh yeah. Sorry. Apologies. Okay. A visual aura would spread over at least 5 minutes. So for example, a visual scotoma can start in the corner and it can move over the course of at least 5 minutes across the visual field, where a sensory disturbance might start as pins and needles in the digits and it might march up the arm. Succession means that at least 2 aura symptoms happen one after the other. So for example, first visual, then sensory, then motor, and so on. The auras are reversible within 60 minutes. At least one of them is unilateral. At least one of them is associated with positive phenomena. So positive phenomena is added function or gain of function phenomena. So for example, in the case of someone that complains that they cannot see, a person with stroke or TIA may not be able to see because they have hemianopia or visual field defect, like there's absence of vision. Whereas in migraine aura is that they actually have like a scotoma or spots of light or fortification phenomena in their visual disturbance. So this is something that gets added on to their perception. For sensory disturbances, the same thing. To patients that present with numbness, the person with stroke or TIA, the numbness is that they have absence of tactile touch. But in someone with migraine aura, is often that they're feeling pins and needles. So they have an added on function. And notably, as you can see, headache is only one of the 6 criteria here. So you can have migraine aura without headache. This table is a summary of the distinguishing features between migraine aura and stroke or TA. I have it here for your reference in case you want to screenshot it. You don't have to go through it in detail, but just to highlight again that positive phenomena is suggestive of migraine aura and negative phenomena is suggestive of stroke or TIA. And I just wanted to highlight too that brainstem symptoms and motor weakness is exceedingly rare with migraine aura, and the first presentation, severe weakness, we should be really thinking about stroke and TIA. Okay, so after diagnosing migraine aura, how do we treat it? Historically, the treatments have changed a little bit. This is an algorithm that we put out a couple of years ago, just summarizing some of the main treatments in migraine. In the emergency department, we would first give a simple analgesic like acetaminophen or paracetamol, along with an anti-inflammatory like ketorolac. We would give either metoclopramide or prochlorperazine. In some emergency departments, sumatriptan was being used, and to reduce recurrence, dexamethasone. And if patients repeat some of these first-line medical therapies, or we could add a second-line therapy like valproic acid, or depending on the availability of your medication, something like magnesium sulfate. Now, as of 2025, the American Headache Society published new guidelines updating the parenteral treatment of migraine. In this panel, there was a mix of neurologists and emergency physicians. So 2 of us were emergency physicians, the rest were neurologists, but everyone here had a headache-focused expertise. We reviewed, out of more than 4,000 papers, we did full text review on more than 300, and 20 were ultimately included in the systematic review. And this was also the first international guideline that harmonized the possible role of nerve blocks in managing headache, along with other parenteral treatments that we would use. So in conclusions, the recommendations that came out of this were prochlorperazine and occipital nerve blocks received a must-offer recommendation. Hydromorphone received a must-not-offer recommendation. As discussed before, there's adverse events usually associated with narcotics. Metoclopramide, ketorolac, sumatriptan, and supraorbital nerve blocks all received a should-offer recommendation. And dexamethasone and valproic acid received a may-offer recommendation. For those that, I think that the uptake of nerve blocks is different depending on the emergency department, but for those that have not incorporated them, here are some of the main ones that you can try for headache-related disorders. If you're going to incorporate one or start with one, the occipital nerve block is one that has quite a bit of evidence, and it's fairly easy to do. So the landmarks are if you feel your occipital protuberance, which is the big bone in the middle, at the back of your head, and then your mastoid process, the greater occipital nerve landmark is 1/3 of the distance between these 2 sites. The lesser occipital nerve block is 1/3 of the additional distance. Okay, so after treating a migraine attack and the patient is discharged, there's a chance that some of them might boomerang back in the emergency department because of headache. How do we reduce this likelihood and prevent repeat ED visits? And here, I would like to frame the concept that treating migraine is very much like treating COPD or treating asthma or treating CHF. Migraine is a chronic condition that is marked by acute exacerbations or acute flares. And in these other conditions, we would often prescribe a controller therapy for asthma or steroids for COPD or furosemide or a diuretic for CHF. And the same idea stands for migraine. So the principles that we can incorporate to reduce the likelihood of headache coming back are first to treat the migraine attack as fully as possible. Think about migraine like a fire. If you blow the fire a little bit and you walk away and you come back, it's going to be roaring just as much. So we just want to abolish the migraine attack. Secondly, it's about equipping patients with the medications that they can use at home to reduce the likelihood that the headache will recur. So this is about providing a prescription for medication. Thirdly, consider providing a prescription for preventive medications for eligible patients, and this can often be pivotal in reducing the likelihood in migraine coming back, but also in making them easier to treat when they do come back. So a migraine kit for home can look something like this. For simple analgesics, I think most people have tried these and often failed if they end up in the emergency department, something like acetaminophen or paracetamol and anti-inflammatories. But you can give a migraine-specific acute medication, like a triptan, for which there's many. Just make sure that that the prescription is for under 9 days per month, as more than that can cause medication or use headache. I usually start with sumatriptan, but you can take your pick. And there are newer agents that also block molecule called CGRP. These are called G-pens. Two of the ones that are readily available are ubrogepant and rimegepant. In the United States, you also have zavegepant. And these agents are really taking, they've been very popular lately. So you will see a lot of patients coming with them. The data suggests that they may be less efficacious than triptans, but the trade-off is higher tolerability. All right, so we're off to the last part, and then we'll close off. How do we incorporate principles of prevention? There are many international guidelines on preventive treatments. The role of preventive therapy has well established. There's recent meta-analysis of more than 64 studies. This is one systematic review that I use because it's Canadian, which is where I practice. This is the Canadian Headache Society guidelines, but there's also the International Headache Society guidelines. And they've all come up with many different medications that you can use for prevention. But what's most practical for an emergency physician is to use medications that we are very familiar with, that we use frequently, that are very safe, have a low likelihood of adverse events, and that are effective. So these are the ones that I would recommend. Candesartan is very effective, typically very well tolerated. The most common side effect is lightheadedness. There should be caution in using it if someone's going to be pregnant imminently, as it should be avoided in pregnancy. Metoprolol and propranolol we should avoid in asthma and COPD. Again, both of them are fairly well tolerated. They can cause some lightheadedness. Amitriptyline can cause some anticholinergic side effects. And in terms of using the medication, patients should use it at night because it might make them sleepy. All right. So in summary, just remember when you have your next person coming with migraine attack, treating migraine attacks as fully as possible, providing a prescription for acute medications, and consider introducing some of these topics of some of these principles of preventive treatment. And I believe that's all I have.
Good now? I think so. Okay. I was just thank you for providing some of those resources that we can use in our toolkit for treating our migraine patients. I agree that a lot of us are not equipping any sort of medications or take-home packs for at discharge time, and I think that's excellent. And also my congratulations to your daughter and her excellent artwork. I loved her drawing. All right, for the sake of time, I think we will move on to learn from Dr. Tarek. Hello, come on up. Thank you, Dr. Cortel-LeBlanc. So next we'll be learning from Tarek Djoudjou about the use of tranexamic acid in GI bleeds. Hello, welcome to the stage.
Hello, everyone. Is my voice hearable? Yeah?
Sounds good.
All right. So this is Dr. Tarek. Today I'm going to talk about IV tranexamic acid in gastrointestinal bleeding. This is the first ever systematic review and meta-analysis that was published in IV tranexamic acid. And that's what concerns us as an emergency physicians. Okay, yeah. So first of all, we all know that gastrointestinal bleeding is a lethal condition that might cause death and mortality. And we know that IV tranexamic acid has been used a lot in a lot of researches, such as CRASH 2, 3, in preventing some bleeding. So we come up, me and my colleagues, with this systematic review, especially that there was a lack of IV tranexamic acid meta-analysis concerning the GI bleeding to see if it does affect the mortality and other outcomes as well. So we followed the PRISMA guidelines. We searched through two search engines, PubMed and Google Scholar, and we did a lot of analysis. We focused on random effect analysis. As a primary analysis, we also did fixed effect, we did subgroup analysis, and we used Cochrane rope tool for bias assessment. And what we wanted to study is the outcomes. We wanted to study 5 outcomes, primarily the mortality as the first, and secondly, rebleeding, failure to control bleeding, thromboembolic events, and blood transfusion requirements. So after all of those search in the engines, we found 7 RCTs that fit the inclusion criteria and the exclusion criteria. We focused on adults, and we had those 7 studies. The recent one was published in 2024 in India. The biggest study that was done was the HALT study in UK, which has the big chunk of our population, which included 12,000 people. And if you notice, there was a lot of studies between so there was a lot of studies going back from 1976 up to 2024. So there's a lot of research throughout the time, and different protocol was also used here. And when we did the risk bias assessment, we found that 2 were unclear, and 1 was high, and the rest were low in risk assessment. The primary outcome, which is mortality, we found that there is no significance in mortality. However, I know most of you will be saying we already gave up on mortality in terms of GI bleeding when it comes to the HALT trial. However, I think we are too early or soon to give up on it, because if you notice in the mortality chart here, we see some kind of trend in reducing the mortality, even though it's not significant. And if we go to the research, the primary RCTs, we found that most of them, they are not differentiating between upper GI or lower GI. They're not using the same protocol, and also they don't have a certain selection on patients. So maybe if we selected certain patients, we might find the benefit of mortality that we all hope to see in IV tranexamic acid. And this will be more clear when we come to the other outcomes. We will see where it was significant. When it comes to blood transfusion requirement, it was also not significant as well. Where it was significant was in reducing rebleeding and failure to control bleeding. It reduced it, so that's where the significance of IV tranexamic happened. And those patients who have that could be a criteria to select some of the patients that we want to use IV tranexamic acid on. When it comes to thromboembolic events, that's where it becomes controversial a bit. We use two analyses for people who are familiar with analysis, meta-analysis. We use something called random effect, and we use something called fixed effect. Usually when we use random effect, we use it when there's a lot of heterogeneity between the studies. So for example, when we have studies from different dates, or we have different protocols, and a lot of other causes that make, for example, different countries as well, all of those contribute to heterogeneity. And we usually use random effect for those patients, or for those studies. And when we used random effect for thromboembolic event, we found that IV tranexamic acid was not significant. However, when we use fixed effect analysis, we saw that there is an increased risk of thromboembolic events. So what's the summary of our finding? We found 7 RCTs. We found that it reduces rebleeding and it reduces failure to control bleeding. We found no significance in mortality or transfusion benefit. The safety overall also was in general was acceptable. However, as we talked about the thromboembolic event, there is a potential risk of thromboembolic events when we did the fixed event analysis. So what is the limitations here? The heterogeneity that we talked about, different people, different protocol that always use, the dates, for example, we talked about the earliest study was in 1976, and the latest one was in 2024, and that might tell us a bit about the heterogeneity of the studies and the implication of it in our society. The variability in the dosing and the protocol, also some of the risk bias. As we talked, they have two with unclear risk bias, only one was high. However, even with those risk bias, we did the subgroup analysis just to make sure that those results and those research are not affecting the overall results of our meta-analysis. Some of you would ask why did we choose only those 5 outcomes. For example, there's other outcomes such as seizures, ICU admission, etc. But however, there is inconsistency in the protocols and the outcomes that were studied between all the studies. So it was hard to conclude all those outcomes. But the 5 outcomes that we came up with this study, those are the most common between all the studies, and that's why we use them. And lastly, there's is my voice clear?
Better.
Yeah.
Better now.
Yeah.
There
Good.
was echo for a second.
All right. Lastly, the last limitation was. In the study, especially at the Hall trial, for example, which is the big chunk of our study, there's no differentiation between the upper GI bleeding and the lower GI bleeding, and that's where the selection of our patients comes. What do we recommend in a nutshell? We don't recommend using IV tranexamic acid as a standardized protocol for any patients who present with GI bleeding. However, we can use it as an an addition therapy, especially if we select the patient that we use the tranexamic acid on. We need to monitor also the thromboembolic potential risk. And definitely we need to do more research on IV tranexamic acid and GI bleeding with more standardized outcomes, and also more selection of which patients that might benefit from the tranexamic acid with the appropriate analysis to know which patient really benefit from it. That's it for me, and thank you so much for your time.
To join us in our discussion zone if anybody has any burning questions. With that, I think that's a great transition into learning about massive transfusion protocols. So we'll welcome up our next speaker, Arif, Mattoo, and another round of applause for our speaker. Thank you so much.
Thank you.
Hello, welcome.
Thank you.
It should be turned on. All right, thank you for joining us, and we are very excited to learn about MTP.
Let's see how it goes. Hi, good afternoon. I'm Dr. Arif. I'm an emergency physician. So let's together deep dive into massive transfusion protocol. It is me in the Red Sea, though I don't like diving, but my wife loves it a lot, so I have to be at it, okay? So it's earlier we used to call it as a massive transfusion protocol, but from a couple of years we call it as a massive hemorrhage protocol because we are dealing with the hemorrhage. It seems quite simple, like the blood is coming and we give the blood back. But at the same time, if you look back, even when we change the oil of the car, we look which brand we will use, how it will work on our engine. So the way it looks very simple, it is not. What happened? Oh.
The one under.
Sorry, technical errors. So, if you know that in medicine, when this opinion is stronger, the weaker is the evidence. Same is like, if you remember, we used to give methylprednisolone in spinal cord injury. It was given like water. But at the end, what we found, the evidence is completely weak. Same is the case over here. So moving further, let us discuss the first 6 steps of ED approach in controlling the hemorrhage. We stop the bleed. Once we try to stop the bleed by any means, we start giving uncrossed blood. based on the hospital protocol. Uncrossed blood, you give 2 units. If you still see that the patient is still not hemodynamically stable, we keep on another 3rd unit, and at the same time we activate protocol-based transfusion, which your hospital follows. We give tranexamic acid, we give supportive care, be it ABCs, hypocalcemias, correct acidosis, monitor vitals, urine output, and at the same time, we need to have some endpoint, how it is going to stop, because we have to stop it. So triggering massive hemorrhagic protocol, it's like for an emergency physician, you are moving on a rope, tight rope. If you activate it, because it's always resource utilized, a lot of resources are being used activating the massive hemorrhage protocol. So if you activate it, it's like huge number. So, and at the same time, it's loss if you activate it unnecessarily. But at the same time, if a patient will die due to bleeding, it's also a loss. So we need to know how to activate the massive hemorrhage protocol. There are multiple decisions like ABCs, TASH scores, rabbit score. ABCs, it's very simple. You have 3 categories. You have systolic blood pressure, you have heart rate, you have your penetrating injuries, or you have a fast scan. But if you go to the evidence or literature, specificity and sensitivity is less than 90%. The studies itself, when I dive deep, it is not that good quality of studies. Same TASH score, a bit more complicated than ABCs, but again, sensitivity and specificity is below 80%. RABD score. Again, they just added, apart from the ABC in the RABD score, they just added the shock index, greater than 1, we activate it. Other than that, nothing. And again, the quality of the study is not that good. So on these tools, are we good enough to activate the massive hemorrhage protocol? I don't think so, not at all. So what we do? The best trigger is you have your clinical concerns. Patient is hemodynamically unstable. You have your physiology. That means patient is in shock, tachycardic, hypoperfusion. You use the tools adjacent with this and early response to blood. Even after 2 units or 3 units of blood giving uncross matched, your patient is still hypoperfusing, you activate the massive hemorrhage protocol. So the best is it should be hybrid model, clinical concerns, physiology, use your tools, you use early blood response. Now let's come to that main talk, that is, we all know the balanced transfusion, 1:1:1. We know that once a patient loses the blood, it doesn't only lose your only the RBCs. There are loss of platelets, there is loss of plasma and all. So there are a lot of discussion whether 1:1:1 is the balanced transfusion or 1:1:2 is the balanced transfusion. So there was a study which was PROP studies. It was done on 780 trauma patients. They found that there is no difference. The endpoint was based on the mortality, and they found that there was no difference between 1:1:1 and 1:1:2. So, sorry. I think there is some. So when they did not find any difference, there was another study which was an observational study done in 1,700 patients. They found that those patients who received plasma and platelets, there was some harm in them. So that means that neither a 1:1 or 1:1:2 is a balanced transfusion. So what we do, we will just dig more deeper. We will separately study plasma, we'll separately study RBCs, we'll separately study the platelets. So there are some potential benefits as well as potential harms while using the plasma. Potential benefits, a lot of coagulation profiles, 2, 5, 7, 8, 9, 10 are done from the plasma. Plasma is a volume expander. At the same time, if you see the transfusion-induced lung injury, the main problem is because of the plasma. And at the same time, main issue is with the allergic reactions happen due to the plasma. So there are some potential benefits, there are some potential harms. So there was a trial which was done, which was a paper trial. It was a randomized control trial, which was done to differentiate between crystallite and plasma. And everybody was happy. Oh, really? Crystallite gives us 33% with 23% mortality. That means giving plasma is 10% less mortality. So we were happy. Oh, we are on the right track. But unfortunately, there was another study which was raffle trial. which completely contraindicates that there is no difference at all between crystallized plasma versus RBCs. It was a randomized control trial done multiple times, and they found there is no difference. So again, while digging more deeper, we were still in the dilemma. What exactly are we doing? Is it right? So what I found in the conclusion that do use it early, because at that time you don't have exact number what was the plasma drop, but avoid routinely, do not give routinely the plasma, which is not good at all. So comes to the platelets. What is the evidence for platelets? If you go to the research, go back and find, you will not find a single research done in the trauma patients using platelets. So I found more deeper, I found there was no harm in giving platelets because there is no study. But there was one study which was known as PASH trial. PASH trial was done in 96 patients or 108 patients who had non-accidental intracranial hemorrhage. It was a study done on the patients who are on antiplatelets. They were given routine treatment and platelet therapy, and they found those who received platelet therapy, there was some harm. There's another trial which is known as PACER trial, which was done on... Okay, so I'll move quickly.
No, sorry, there was echo, you're good now.
Okay, so platelet practical conclusion is it should be a goal-directed therapy. There is nothing permanently. So whole blood, theoretically it looks better. If you see, there is a comparison, there's a hematocrit, while 1:1:1 is 29%, whole blood gives you 43%, platelets is getting more, coagulation activity is more. Theoretically it looks sound better. We give whole blood rather than giving this because it shows us its comparison is very good. But unfortunately there was one RCT on 107 trauma patients. In first 24 hours there was no difference in mortality, but there was almost 22% versus 14% mortality in those patients who received, but this was a good number. So tranexamic acid, I don't want to discuss, my colleague discussed, but if you go to all the trials done on the tranexamic acid, only CRASH-2 trial and CASH-3 trial tells us about tranexamic acid use. Other than that, HALTED, NOPAC, women trial, TRAP1, TRAP2, none of the trial was positive related to tranexamic acid. So there is still tremendous uncertainty. So the present literature shows that follow hospital protocols, whether you go for 1:1, 1:1, or 1:1:2. But what I suggest, the only thing matters is testing is delayed. If testing, it should go for empirically 1:1:1 or 1:1:2 when the testing is delayed. Just one more slide, that's it. So point of care testing is more important. If you go to the literature, give the thing which is deficient. If platelets is deficient, give platelet. If the plasma is deficient, give plasma. If the calcium is deficient, give calcium, and all, not randomly giving everything which is not good. So we should work, rather than working on 1:1:1, 1:1:2, whatever plasma, platelets, we should work on point of care testing, which is more important. So take home message, the best MTP starts within first 10 minutes when we analyze whether we need to activate or not, and the next 60 minutes are very crucial. So let's keep on diving and never explore the unknown. That's it. Thank you.
Excellent. Thank you so much for joining us. I really love your analogy about the car oil because I don't know a lot about that, but this is really helpful and I like that you broke it down for us.
Thank you so much.
Thank you so much. Next, we'll welcome up our final speaker of this session, Dr. Gabin. Hello, welcome to the stage. Nice to meet you. Gabin's going to be giving us a story. I'm excited to hear. Thank you.
Thank you very much for your introduction. I'm Gabin Mbanjumucyo. I'm an emergency medicine physician. I currently work in the UK, but also I work in Rwanda. That's where I am from. I'm going to talk about mostly system approach in low and middle income countries. And let's start our slide with with a little bit of story. So we have a 35-year-old female patient who just been hit by a car in front of her emergency department, and she comes in with her child, who has a distended abdomen. After you've done your thorough ABCD, you find that the child is distended abdomen, and you think that's what's causing, the shock. And the mother has bled from the scalp. It's been reported by the pre-hospital or whoever brought her in. But unfortunately, you're working in a limited resource settings, and you have only one nurse available. You have 2 units of blood, and you have 1 ventilator. You have a surgeon in the hospital, but the surgeon is in theater, and they'll be, they will show up at some point. And despite your resuscitation, their level of consciousness drop. This is a story that might relate to you in different ways. We always have such stories in limited resource settings, also in other settings. During COVID time, we were faced more or less with these stories. With recent studies, it's been shown that there is more report of moral injury. So what's moral injury? It's when you have a case and you want to provide the best care, but because of the resources available, unfortunately, you can't. During COVID, you would have patients who come in and you want to save everyone, but unfortunately, you had to make that choice. I'm pretty sure everybody was around during COVID. And in mass casualty events, in pandemics as well, there's, once in a while will be pandemics, the world becomes more popular. There'll be more pandemics, and we'll be faced by these decisions. One of the other reasons is people are, there is more research in limited and low-income countries, and we tend to, hear more about it, and people are speaking up. But let's give credit where it's due. In overall mortality has been going down. Let's talk about in sub-Saharan Africa. It's I know low and middle-income countries, by the way, even in high-income countries, even in the UK, there are some remote places where there will be no on-calls overnight. It would be a little bit difficult. You will not get an X-ray overnight. So let's not just, it can be anywhere. So we can say that mortality is coming down in sub-Saharan Africa. There could be so many explanations. It could be less conflicts, better healthcare, better of everything. But as with development also, development is not, it's good, but also it comes with its own curses, We are seeing more road traffic accidents. People can afford cars when they are younger. Their roads maybe not that good. People can buy a second-hand car, a little bit fast, but not that safe. So there are more and more of increase in road traffic accident. So we are seeing more moral injury stories, wherein the government has not invested, the decision makers have not invested that much in relation to how the country is needing. And as you can see, in 2050, Africa will be one of the most populous, continents in the world. So if you're a decision maker and you'll be working there, you have to anticipate and plan way ahead. Okay, so let's look at one graph, but we also bring in moral injury from approaching from a perspective, and maybe this graph we can talk about it. So this is from Rwanda, and I'm from Rwanda as well. And in Rwanda, it's one of the countries that people speak about is developing well economically and healthcare system. But let's try to look at this graph and try to interpret it. In green here, we have the life expectancy. So life expectancy is going up, which is a good thing. In 1994, it used to be 25 years old, 25 years. Now it's around 70. It's going to projected to be 75 in the next 10 years. It's a good thing, but also not. I mean, if you're a decision maker there, you have to think, pension and all the other things that come with the age. Infectious disease have significantly come down, So, which is also a good thing if you're a decision maker. But let's look at the graph in, I would say pink there, down there, on orange. What's happening to that? And maybe that's under-relating it to moral injury story. As you can see in 2000, for the last 20 years, the number of non-communicable diseases have not increased. And that should not be the case. So when I was looking at it, when people put it out there, I was like, things are not adding up. If a country is developing and infectious diseases are coming down, we should expect non-communicable diseases to go up. Unless people are eating healthy and everyone is going to the gym after work, which I don't think is a story. So what's happening here is the diagnosis of non-communicable diseases has not changed for the last 25 years. So if you're an emergency physician or a physician down in working there, you are, you are faced up with patients because the WHO or MDGs tend to fund things like tuberculosis, HIV, and we tend to forget about other things. We don't project in future. We don't look 20 years ahead. What's going to happen? Okay, if you don't have tuberculosis anymore, what's going to happen? Are we going to, if the income per family goes from $100 per month and it's 1,000, I'm pretty sure they are going to be eating French fries at night. They're not going to be just eating, and people are going to drive. They're not going to walk for 10 kilometers. They are going to drive. So that means and non-communicable diseases should be increasing. So if you look at this graph, it does not make sense. There's something missing there. And that's where now, as a physician, you would be faced with dilemmas because I don't have enough to diagnose whatever I'm being faced with. And looking at the last graph here, so what we can see as well in sub-Saharan Africa and in funding, we can see that government funding is not growing according to the population needs, which is something as well. As a healthcare practitioner or someone, if you are in decision making, you should be worried about. As you can see in red, the funding is drying out. Money is not coming in. And as a decision maker, you have to be worried about that. Because if the money is not coming in as it used to be, then the health systems will not be funded in the next 20 years. So moral injury is going to be increasing. And moral injury is a concept which was mostly described by military. If you're in the military, you're on the front line, and you are faced with the dilemmas on who to save. Your colleague is being injured. Should you run away? Probably that's what you are told as in emergency medicine, approach a patient if he's safe, or should you save your colleague? So that's where moral injury is mostly reported. And now it's coming to the medical field, and we are being, as frontline workers, we are being faced with the same decision. Who should we save? What should we do if I don't have this? And that's why we are having increased depression, increased number of people quitting. It's also contributing to burnout. Okay, so what should we do? As we are here now, yes, we are reporting it, we are publishing about it, so what should we do? Should we just run away? Should we let the government decide? Or should we, what should we do? So one of the approaches of trying to find a solution is we can go through the 5 whys. And in our case that we just talked about, we are going to approach it in a 5 why, trying to find the root cause. It's not the right answer, but it's just something to brainstorm here and to give you something to think about, okay? So why did this, if we go to the case of this physician who is faced by dilemmas on who to save and what to give, and why did the clinician eventually have moral injury? Okay? It's because they had to make a decision between who to save. I mean, that's pretty obvious. If you are faced by that and, you are in front and everybody wants to save everyone, but unfortunately it's not always the case. Okay? So you are put in that dilemma. But why is the physician put in that dilemma? Okay, if you go down, because the departments, everybody has a boss. Everybody has a boss. So the department lacked the adequate contingency plan. So the department never planned for that. They were like, okay, 1 in, 1 out. We don't expect 2 people to come in. And, whoever is in the decision in that department probably had not thought about that. Okay? And why was that then? If we go down with 5 whys. Okay, because system-wide pressures. If you are a clinical lead in the department or you are the medical director, I have other things to think about. The funding of the government or the funding of the hospital is around WHO goals, MDG, HIV, trauma. Fine, we think about it, but nobody's going to look after that data. We want to make our data in infectious disease look fine so that we get extra funding. That might be one of the questions. But also workforce shortages. Maybe there was not enough or they can't afford to hire more. Okay, funding, money drives the system. Wherever you are, money has to come in. If you're making a decision, money always drives the system. So maybe there was not enough of that. But why was that? Okay, because there was no strategic plans. Whoever is making higher decisions never thought about that. There is no funding allocation. We can always fund, we can always allocate to what we think is more important. But also, don't forget about that decision makers go around all these governments. Someone has to vote for them. So, all these things will be around that. So we have to openly think about the politics behind funding of systems. It's about, I want also to be now, I want 10 people to walk around me and in an unarmored car. So I want to keep that position. And that might be one of the things. So that drives the system. But now that's where we want to change. And why was that? It's because of the old mindset. And when deciding this, we have had clinicians, we have had these stories for a long time. And we tend to think that systems that thrive well are systems that are resilient. But we want clinicians, put them in this position of resilience without providing them with equipment or guidelines or funding that need to make them resilient. So while looking at this, finally, with the final slide, if you are in these settings, what you need to change is the mindset. So we want to advocate for mindset change, so that from scarcity mindset of people are waiting for funding, not allocating, funding, and we are silent about it. We tend to have more injury and burnout. We want to have shared responsibility. We want to talk openly about it. We want to have better systems that cater for this. And we want to have meaningful workforce and also well-being of our systems. So overall, when looking at moral injury, it's not just about a story that we do have, it's about a mindset change. And if you're making decisions in limited and resource, you have to think the whole system have to to have a mindset change from the clinician giving to the up to the decision makers. Thank you very much for your time.
Thank you so much for that. That was wonderful. And I think that this is a very important topic. This entire session was about critical decisions in the emergency department, but you tap on a very kind of sensitive area that I think a lot of people aren't willing to talk about. So I appreciate that. With that, we will wrap up our session, but I invite you all to stick around for our discussion zone if anybody has any pressing questions for any of our excellent speakers. Before that, though, one final round of applause for all of our speakers. We appreciate their time today. Any questions or thoughts on any of our speakers today? I have a question for you, Dr. Gabin. My question to you, in the face of some of these moral injuries that a lot of us are facing that might be undiagnosed, if you will, what is kind of your personal treatment plan for yourself or for any of your colleagues whenever you see that they're facing a moral injury? How do you cope or manage one of these situations?
Yeah, that's a very good question. And one of the sessions is about approaching these physicians who are faced with this, trying to find, one-to-one talks, but also trying to talk to them with the whole group and trying to address some of these. It's not a straightforward, thing that you do, but trying to approach them, see what they have, try to advocate in our system world, to the decision makers up high, and try to solve them. We don't want to develop, the mindset of, this is normal, and we stop there.
I agree. I think that's a very strong point, that just not normalizing something like that and acknowledging when something very tragic has happened in front of our eyes. So I appreciate that. One thing that my institution is trying to get a little bit better on is debriefing after running a code or dealing with a really critical patient. So do you have any thoughts on that?
So definitely debriefing, especially in emergency medicine, it's something that's become routine. And it's quite good, to pick up these things, to pick up moral injury immediately and try to address them and avoid them to become chronic. So it's a really good thing to do debriefing immediately and to be open and non-judgmental as well.
I agree. Thank you. Does anybody else have any other thoughts or questions for any of our speakers today? thank you guys so much for joining us this afternoon.